Welcome to this GU Cast Conference Highlights. That's right, it's our first conference highlight podcast of the year. Renu took herself off to San Francisco for ASCO GU a couple of weeks ago, one of our favourite GU oncology meetings in the world, always in beautiful San Francisco. We sent her off with a camera and a couple of microphones to see who she could track down, and she's put together a wonderful package with some great plenary speakers and reactions from well-known faces that you might recognise. Plus, she got out and about in San Francisco. Don't miss her segment with Tyler Seibert when they went for an early morning jog around beautiful San Francisco. This podcast is brought to you with the support of our new partners, Bayer in China. Bayer have come on board as gold partners of the podcast, and we'll be talking to you about that very soon because we're going to bring you some themed podcasts focusing on GU oncology in China. And they're also supporting our conference highlights podcast throughout the year. ASCO GU is the first of them, but we'll be coming at you very soon with highlights from USAN's meeting in Adelaide, EAU in Paris, APCCC in Lugano, and so on and so forth. So thank you very much to our friends at Bayer in China for supporting these conference highlight packages. So let's hand over to Renu and see what she got up to.
All right, so here I am with Matt Cooperberg from UCSF. Hello, Matt.
Hello, great to see you.
You too, and ASCO GU back in your hometown of San Francisco. Always good to be back.
Always good. The weather's cooperating finally.
I had a good fellowship, so I don't get PTSD,
Good,
in case you're wondering.
Glad to hear it.
So yeah, it's turning out to be a great meeting. What are your highlights so far?
Always a great meeting.
Yeah.
It's amazing to see everybody back. Packed hall, 2,000 people, 350
Absolutely.
Posters.
Great turnout,
It's a fantastic meeting.
Yeah.
I think the highlights on really targeting treatments for men with systemic disease this morning were fascinating, and I think it's getting us closer to figuring out how we can really tailor treatment.
Yeah.
The missing piece there is tailoring the treatments to the specific patients based on biology.
Correct.
And I think the other piece that was missing from this morning, but is on a poster downstairs, is the financial toxicity piece. And there is a poster. I'm forgetting who wrote it currently, but they estimated just based on the specific combinations, olaparib versus talazoparib, and Abi over Enza, was like $350 million to the U.S. alone. Depending on exactly how the regimens are chosen and given out. That's something we need to keep talking about a little bit more.
Absolutely. I think when we do talk about toxicity, financial toxicity is a huge thing. I remember David Penson's talks on it. And absolutely, we need to keep focusing in this era of treatment intensification. Let's get back to your pet project here, which is the Gleason-Grey Group 1 debate. And we saw Scott Egner take the side for yes, we should rename, and Martin Gleave deliver the opposition. What are your thoughts on the outcome? Who won?
Well, first of all, I think the baseline numbers say it's no longer a pet project of anybody's. There's a number of us writing on it, but I think there's more and more people that are warming up to the idea, at least in theory, of thinking about different nomenclature for what we're now calling grade group 1 cancer. I think we could have predicted Martin Gleave, out of all the people who have spoken against this idea, was going to be one of the more formidable opponents, as it were. And, and in fact, the numbers, the baseline audience numbers were better than I would have expected. 47% were kind of favorable to the idea, only 35% after the debate, which again speaks to Marty, I think, more than Marty's science. I think the delivery was compelling.
Or whoever agrees that we should rename just left after Scott's talk.
That's quite possible too. That is very possible. I think at the end of the day, though, two arguments of Scott's that are highly compelling. One, which is the most important one at the end of the day, is no matter what you think about nomenclature, ontology, histology, molecular biology, public health will be better if they make this change. For all the reasons that Scott highlighted, but also for the reason that he did not raise this time, but he has raised in the past, and I have as well, which is if we really end overdiagnosis and overtreatment, and this would be the greatest step toward achieving that goal, then the risk-benefit ratio for screening becomes incontrovertible. And if we can sell to the decision makers who control screening policy, in this country the USPSTF and others, that overdiagnosis and overtreatment are truly a thing of the past, then we will save so many thousands of lives through better use of PSA testing that the small number, and this number is not zero, the small number of men who will ignore the diagnosis of something other than cancer, not follow up as they should, not do the surveillance, and maybe be lost, those numbers, again, that number is over zero, but it is much, much less than the number potentially saved. So that's one point. And the other is a little bit philosophical, and both the speakers kind of got at this in different ways, which is, what is cancer? The nature of what is cancer. For 3,500 years, for more, going back before Hippocrates, people had an understanding of what cancer was, and cancer is something clinical. It spreads and it kills you. And no matter what we have evolved to say in the treating community, that is still what, not only patients, that is what the world knows cancer to be.
Yeah.
For the last 150 odd years, we've been defining cancer based on what it looks like under the microscope. And for a while, that was still based on things we would find clinically. We'd find a lump, find a tumor, biopsy it, and figure out what it looks like histologically. It's only very recently that we're now screening and diagnosing things based on bits of tissue years and decades before they would cause any symptoms. Well, now, fast forward another 50 years, now we are understanding molecular biology, and we're digging much deeper into what actually makes these things tick. And what we are learning, without any question, is that there is a continuum of biology from actually normal to quite altered at the molecular level, but completely normal under the microscope, to pre-malignant, to low-grade, to high-grade. We see this in prostate, we see this in breast, and lots of other tumors. We have to be honest with ourselves that defining cancer based on the moment in that evolution where suddenly we see something under the microscope is, from a clinical standpoint, completely arbitrary. It is. It always has been. It's because we have this 200-year-old technology that we've been using for so many years effectively, but now we can do better. So there is absolutely no clinical or epidemiologic reason that we cannot shift that line in terms of when do we use the C word one step to the right, and get to the question of when something might actually be a problem. Neither Scott nor I nor anybody else involved with this debate has ever said we should call it normal. We all have said very clearly this needs to be followed. Active surveillance should look exactly like it does now. We need to rebiopsy, we need to do imaging, because those that progress we will see, and we will treat with every intention and expectation of cure.
Now, Matt, it was exactly a year ago at the last ASCO GU that you held the inaugural Great Group 1 conference. It was a pleasure to attend, and what I do... I think it's still recording.
I think it is, but I'm just standing here holding it.
Okay. Now, it was a year ago at ASCO GU last year that you held the inaugural Great Group 1 meeting at UCSF, and it was a pleasure to attend it. But I do remember the pathologists that attended essentially said, and what was the term they used? It was dead on arrival. Do you think we're any closer? I mean, you would have to have their support to do something like this. Are we any closer a year later?
I think so. The nature of that meeting, the GG1 cancer with a question mark meeting that we held last year, it was by design very much both international and interdisciplinary. We had a number of pathologists there, not enough, but we had some very prominent international pathologists in the room, and they have mixed opinions. A couple of them who were there have now signed on to a statement by pathologists saying we should consider nomenclature change. A couple of the others are, as you say, consider it dead on arrival, don't even want to be part of the publication because they feel very strongly about it. If you look at the paper that Glad Panera put out with Scott and others, polling both urologists and pathologists, not surprisingly, the two things that are not surprising: number one, urologists are warmer to the idea than pathologists on average. There's also, not surprisingly, a generational issue here, and younger people are warmer to the idea than older people, both in pathology and in urology. The older pathologists are the least interested. The younger clinicians are, I think, the most open to the idea, which tells us, to me, that look, we're on the right side of history long term. It might take a while. We absolutely need pathologist buy-in eventually and engagement, and we've been talking about what the next step in that symposium should be, and I think we all feel like we need to do something in a pathology venue with more molecular biologists, with more pathologists, and really drill deeper into this issue, not just what is prostate cancer, but what is cancer. Some of these other examples, these counterexamples that come up all the time, basal cell of the skin, well, no, that's really not cancer either. It's a tumor that spreads, that can cause problems, but it doesn't metastasize and kill, right? Whereas other things that they say, well, you can have a benign brain tumor, that's different. It's a mass effect. The things at the end of the day, we need to understand that no matter what debates we have, patients still hear these terms that resonate very deep in human history. It's not going to change overnight. No matter how much we can talk about active surveillance, there's no getting around the anxiety problem. There was just a study in European urology out of Sweden, even in contemporary practice, there's an increase in suicide rates, even after diagnosis of grade 1 cancer. It's crazy. Men still lose their life insurance with this diagnosis.
Insane.
It's crazy. So, it's not just prostate. Prostate is probably the biggest kind of public health example here, closely followed by breast cancer, where DCIS is, my understanding is, it's not my area, it will occasionally metastasize, whereas grade group 1 never does. So maybe we have an easier case.
Yeah.
But there are lots of other examples there where we need to be thinking more broadly in oncology what this word means.
Yeah. And you're working on the manuscript, and we
the
can
manuscript
hopefully
is
expect
they're very international,
Yeah.
interdisciplinary panel, so lots
Very
of
good.
cats to herd. But this is 1,000 words that have been vetted 50
Absolutely.
times over. But the paper will go out soon and hopefully keep driving the conversation forward. It's very exciting.
Fantastic. Well, thank you for your efforts, Matt, and good
Always a
luck in your
pleasure.
mission.
Always a pleasure. Thanks so much.
All right, so I'm here with Todd Morgan, urologist from the University of Michigan and convener of ASCO GU 2024. Congratulations, Todd.
Hey, thanks. It's like we're almost done.
Almost done. You're at the end of day 3.
It's been awesome.
It's been an awesome 3 days. What have been your highlights?
Well, for me, just being here and seeing this happen after a full year of work.
Yeah.
It's really rewarding. But we've had great talks. I mean, Toni Choueiri's keynote 564 presentation this morning with
huge.
applause in the middle. I was like, get chilled. You can see he's getting a little bit emotional up there. I mean, an overall survival difference in an adjuvant trial in kidney cancer is unbelievable.
Yeah, and like you said, it's about 50 years in the making.
It's about, that's what he said. I loved how he put it in that context and thanked all the patients and all the negative studies, right?
Yeah.
In addition to the patients that were in this trial that it's, made this eye-opening difference.
Yeah, I think definitely one of the biggest highlights of the meeting. One thing I'm super proud of is that there's a urologist as convener of a very multidisciplinary meeting.
Yeah.
Was it challenging for you?
I mean, I love it. I just I love working with medical oncology and radiation oncology, and I love developing expertise that's kind of beyond our usual, and sometimes relatively narrow focus.
Yeah.
And that's something that just really appeals to me, and I guess I get a lot out of.
And why do you think this should be a go-to conference for urologists who are interested in oncology?
I think that's it. It's we're pretty good at surgery.
Yeah.
We're pretty good at talking to patients about surgery or about active surveillance, say, for prostate cancer, or the things that are really sometimes very narrowly in our wheelhouse. But it's so helpful to be able to speak to what's going on in radiation oncology and what's going on in medical oncology and pathology, all the new classifications of renal cell carcinoma, for example. And so this is the place where you can come and rub elbows with people in all these different fields and learn their expertise.
Yeah.
And the more expertise we have outside of our domain, I think the better doctors we are.
Yeah, absolutely. And I think that's what makes this meeting so unique, when you compare it to the AUA or the EAU meeting. It's a big meeting, but it still has a small meeting feel, and it's great for networking, right?
It's so great. I mean, you get to make so many friends that are not urologists. I love urologists, but I also love medical oncologists, and I love the radiation oncologists and all the other folks we get to work with.
Fantastic. So what are you going to do with all your spare time over the next few weeks? You're done?
Yeah, I mean, believe it or not, so we're going to debrief this meeting in a few weeks. And then about a month later, we get to start planning ASCO GU 2025.
Fantastic.
And it's going to be awesome.
It's going to be awesome. Come to ASCO GU 2025. Thank you, Todd Morgan.
Thanks so much.
Okay, so I'm here with Professor Neeraj Agarwal. He's the Director of GU Oncology at the Huntsman Cancer Center in Utah. Neeraj, a fantastic ASCO GU for you. The morning was really all about you. Let's talk about the big highlights of the morning session. Contact 02.
Yeah, it's always a pleasure to be here. Thank you so much. Contact 2, as we know, is a phase 3 trial in patients who have had disease progression on novel hormonal therapy. And we decided to select a patient population with extrapelvic soft tissue metastasis, liver, visceral, or lymph node metastasis. And this is based on the COMET-1 trial, which was conducted 10 years ago. Unfortunately, the trial was negative with single-agent cabozantinib versus prednisone in the post-NHT, post-chemotherapy setting. And although the trial was negative, for overall survival, we did see some signal in patients with visceral metastasis.
Yeah.
And then fast forward 2017, when Dr. Monty Paul and I was involved in that, we did a multi-cohort phase 1 study of cabozantinib with atezolizumab based on the rationale, preclinical rationale, that cabozantinib, being a TKI, would enhance the efficacy of immune checkpoint inhibitors.
Right.
And we did see some good signals there.
Yeah.
Based on all these data, we decided to design this trial in patients who have disease progression on NHT and have extrapelvic lymph node metastasis or visceral metastasis.
Yeah.
In fact, 40% patients had visceral metastasis, and up to quarter of patients, 24% patients have liver metastasis. It's a very different patient population compared to what we see in PSMA-4 trial, where 5% patients have visceral metastasis, or most of the trials.
Yeah.
And just to give you the result of the control arm, for a moment to give the perspective, the median overall survival of the control arm is 14.6 months.
And these are patients who are exposed to a second NHT. That's the control arm?
So control arm was, yes, second NHT, alternate NHT. And control arm median OS was 14.6 months. Just to put things in perspective, this is the median overall survival of glioblastoma, GBM.
Yeah.
So I want the listeners to perceive or analyze these data from the perspective of the setting.
Yeah, this is a very poor prognosis group of patients.
Exactly.
Yeah.
This is not newly diagnosed metastatic prostate cancer who are going to live for years. This is pretty much 1 year overall survival. So in this setting, we decided to choose the control arm of NHT versus cabo-atezo combination, cabozantinib plus atezolizumab. And again, the control arm was chosen to be NHT because that is the most commonly used sequencing in the United States. And wherever it is available, chemotherapy used is not preferred by patients. It has toxicities, and in fact, real-world use of chemotherapy is confined to 30% or less in MCRPC setting, despite level 1 evidence being there for two decades now. In hormone-sensitive setting, at least in the US, less than 10% patients use chemotherapy, despite 1 year survival seen in the Chartered study. And of course, regulatory bodies have agreed to control arm being NHT in pretty much all MCRPC trials in a post-NHT setting. So this is the context of the trial. So talking about the patient population, as I said, 40% patients had visceral metastasis, up to a quarter of patients with liver metastasis, and the progression-free survival, which was the one of the dual primary endpoints, and it was assessed very strictly by RECIST 1.1 in patients with measurable disease, soft tissue disease. So there is no ambiguity about RECIST 1.1 in general. You see the lesions progressing, and once they progress, it is progression. Although, to satisfy the questions among the minds of providers and patients, we also looked at PFS by PCWG3 in bone metastasis population. So the PFS hazard ratio was 0.65. There was a 35% reduction in risk of progression or death with cabo-atezo versus control. And this was consistent as far as RPFS by PCWG3 is concerned. We saw similar PFS. So there is no ambiguity about PFS being improved
because of one definition or another.
Exactly.
And what about the toxicity in the area of combination cabo-atezolizumab in patients who already have a heavy burden of metastatic disease?
So before I talk about the toxicity, really quick, there were 3 subgroups of interest, clinical subgroups. Liver metastasis, because we have really nothing out there for patients with liver metastasis. As I said during my discussion, that the cabazitaxel versus NHT, the PFS hazard ratio for visceral metastasis was 0.79. In our patient population, in liver metastasis, which behaves more aggressively than visceral metastasis, the hazard ratio for PFS was 0.43. So 57% reduction in risk of progression or death in liver met patients. Post-docetaxel patients in our trial, PFS hazard ratio was 0.57. These are all very interesting, very impressive. Doubling of PFS in pre-docetaxel setting in patients who received docetaxel, tripling of PFS in patients with liver metastasis, and of course we saw 33% reduction in risk of progression or death in bone metastasis patient population. So with these data, let's talk about the toxicities. So yes, we saw more toxicities with cabo-atezo. Treatment emergent toxicities were 48% versus 23%. However, there were no safety signals. This combination is widely used in the community. Nivo is a very widely used combination. And we all know that most of the toxicities is driven by TKI-related toxicities. But if you really look at grade 3-4 toxicities, which were the commonest, hypertension, 7%, 6% anemia, which was actually less common than the control arm, diarrhea and fatigue, 4%. So these were the common grade 3-4 toxicities, and we know we can manage these toxicities in the clinic.
So Neeraj, if we put it into context, let's say in the era now where we have lutetium PSMA for the treatment of MCRPC, where does this combination treatment fit? Do you sequence it? Have you looked at PSMA expression in these lesions?
Fantastic question. We know from the studies, and more studies will be presented in the near future, that patients who have liver metastasis, they likely have the lowest PSMA expression among all the metastatic sites. So we know as patients progress with prostate cancer and they have visceral metastasis, PSMA expression goes down. Not surprisingly, in the PSMA-4 trial, if you look at the lutetium trials, liver metastasis patient population comprise 5%
Very
or less.
Low comparatively,
So I would say we want these agents to be available for our patients in the clinic so that we can make the decision. We all do that all the time. You look at lung cancer, look at myeloma, there are so many drugs approved. And many of them are approved based on PFS benefits. I think, I'm really hoping that the combination gets approved so that if I see a patient with liver metastasis, and just for the sake of discussion, because you asked, liver metastasis, PSMA expression is not high. And clearly,
you're right. Not everyone is suitable for lutetium PSMA
treatment. Even the availability of lutetium 177.
Absolutely. And it was a great presentation. I really enjoyed the panel discussion afterwards. I thought it addressed a lot of really great points. Now, the other study we should focus on is the BRCA study that was presented by Dr. Maher Hussain, and you're a co-author on the study as well. Tell us about that. That's about, again, looking at sequencing of PARP inhibition plus and second-line anti-androgen, or giving it in sequence altogether.
Yes, I think the study was unique from the perspective of having olaparib as one of the arms. So we presented TALAPRO-2 study last year. Our colleagues presented Magnitude trial and then Propel trial. I think all of those trials, as we know, all of those trials compared combination of ARPI plus the PARP inhibitor versus an ARPI or NHT. This trial, BRCA trial, is unique because it has 3 arms: single agent PARP inhibitor, single agent AR inhibitor, and then doublet.
Combination.
And the interesting part was, I'll come right to the point. We have debated since last year, since we presented TALAPRO-2 and other trials, that why we cannot sequence these agents, why to give them upfront. And I think to some extent, with the caveat that BRCA trial is an investigator-initiated trial. It was a small trial, 20 patients in each arm. So obviously, it doesn't settle the debate completely. But if you look at the signals, if you combine the sequencing of abiraterone plus followed by olaparib, or olaparib followed by abiraterone, the median PFS is 16 months. And if you look at the PFS of the combination, there is 39 months.
Significant
that is double.
difference.
So that tells us that there's some synergy out there between the AR inhibitor and PARP inhibitor. And I think based on these data, I would lean towards offering combination therapy of PARP inhibitor and ARPI or AR targeting agents in my clinic.
And just to clarify, this is specifically looking, like the name of the trial suggests, specifically looking at patients with BRCA1, BRCA2 and ATM mutations.
Absolutely. Thanks for pointing that out. Yes, patients with HRR mutations, so BRCA1, BRCA2 and ATM. I would like to bring your attention to one one observation we had in this trial, that after abiraterone failed the patients, only half of the patients actually could go on to receive olaparib. Even in olaparib arm, almost half of the patients could not get abiraterone. And that tells us that intensification works in prostate cancer. Whether it is hormone-sensitive prostate cancer or is first-line MCRPC,
Yeah.
I think we ought to intensify.
I think that's a good point, isn't it? Because, and you've said this before, in the real world, not a lot of patients get the opportunity to have multiple treatments one after the other. And that old saying of give your best treatments up front is really valid here.
Absolutely. Circling back to chemotherapy, the median line of therapies in MCRPC given to our patients in the US is 1.4. And chemotherapy has been approved for the last 2 decades. And this tells us that most patients would rather pursue palliative care but will not get chemotherapy.
Yeah.
And this is another observation I'd like to make from this.
We could talk forever, but Neeraj Agarwal, thank you so much for joining us. Congratulations on your studies and for continuing to push the envelope for patients with prostate cancer.
Thank you very much for having me.
All right, well, I'm here with 2 superstars in prostate cancer, 2 of my favorite radiation oncologists. We've got Dr. Neha Vapiwala here and Dr. Sophia Kamran. Ladies, welcome to ASCO GU.
Thank you. Excited to be here.
It's the first morning. Have you had a good day so far?
Yeah, so far, yeah.
Yeah, and it was a very interesting morning. So the abstract session this morning, Neha, you were a discussant in the second half of the session. Very interesting discussion. The GTAC 18 trial, maybe you could just summarize it quickly for us and the main take-home points.
Thank you. Yeah, so I think I'll just start with the take-home point. Seeing that escalation of dose with radiation therapy when delivered with modern techniques, which of course can be done safely and with patient toxicity always in mind, that dose escalation resulted in a survival benefit, period. And I think we are so accustomed to this idea that local control is important, but again, in high-risk disease, we must always be thinking about micrometastatic disease. That is absolutely true. And certainly, long-term androgen deprivation therapy was given to all patients in that study. The goal was 3 years. Most patients did get 24 to 30 months. But really what the test of the study was, the true experimental question was 70 gray versus 80 gray. And for us to be able to see for essentially the first time in prostate cancer literature that not only was the primary endpoint of clinical and biochemical progression-free survival met beautifully, statistically significantly, but also the prostate cancer-specific survival and overall survival. And to the point of toxicity, that is important, and we don't want to, certainly avoid that discussion because it does matter. Even grade 2 toxicity does matter to patients. But the truth of the matter is it was very well tolerated, and we know that with increasing use of stereotactic body radiation therapy, HDR brachytherapy, there's many ways to achieve dose escalation and continue to improve the safety profile.
Yeah, so, first-time results, Sophia, I mean, pretty amazing, and you tweeted about this already this morning. Are we missing something here? Dose escalation, radiation, overall survival benefit.
Absolutely.
What are the caveats here? What should we be careful of? Is there really such thing as no added toxicity?
That's a great question. Yes, thank you. So I would like to echo what Dr. Vapiwala just said. So, I mean, this is amazing. This is amazing data. This is the first time there's been so many dose escalation trials that have been performed, and they to date have not shown or demonstrated an overall survival benefit. So this is a big deal. I mean, this was shocking. I think the community, our field is very surprised, but we're ecstatic because it makes sense that local control, portends systemic control. Like, you have to start with the initial disease, where the disease starts. So that's fabulous. And I think that, I think things that we have to think about, absolutely the toxicity. So, I mean, they said no added long-term GU or just general toxicity, but I think we have to kind of look more, at the minutia of that. We need to really look at what is actually, the breakdown between the patients. Of course, the dose escalated arm, the majority of patients received IMRT. So again, going back to if you have the appropriate techniques, you're using modern techniques, maybe that's, driving this benefit of overall survival. But we do need to always think about, patient-reported outcomes, the physician-graded toxicities, and, think about what's best for our patients, absolutely. But this is extremely exciting. I'd like to also look at, this appears to have been all conventional fractionation data, or fractionation schemes, so it'd be interesting to know, we are now moving into the direction of more and more hypofractionation, SPRT. There's the FLAME trial with the microboosting of the prostate. It'd be interesting to kind of see, how does that all play a role now that we have this data that we can dose escalate and it, it has a survival benefit.
Absolutely. And Neha, you had a really important role this morning, because what I find is when I come to these meetings, it's amazing that you've got data flying out there. There's progression-free survival, there's overall survival, there's prostate cancer-specific survival, and there's treatment intensification. Yeah. But you need someone to put it all into perspective, which is sort of what you did up there this morning beautifully well.
Thank you.
How do we select patients for this treatment? Yes. Is this the way forward now? Because when I hear long-term toxicity, I think, well, what about the really long-term toxicity?
Right.
These patients are going to survive longer, and, not only do you have to counsel patients, but you probably have to convince a few urologists to get on board who deal with the maybe the complications in the long run. So how do you select patients for this treatment now?
No, absolutely. And I think it is important to have that humility, right? I think as radiation oncologists, we aren't always able to see and care for our patients 10 years, 15 years out. And a lot of our colleagues do have memories of older techniques of radiation and delivery methods that have resulted in unfortunate toxicities. I'd like to believe that as we put aside some of those fears while being very much aware of them, but really try to look forward and say, can we, as colleagues, both with our medical oncologists and surgical colleagues, decide for a given patient, what are the priorities, what are their goals of care? We talk about this term informed decision making, right? But so much of it is actually a patient being able to comprehend what is the trade-off that I might experience, even in the short term. And this came up in the quality of life data. When you ask them matters. And if you're talking about patients who are post-operative high risk, right? They're all still struggling to recover. Would they have recovered were it not for your treatment? You've now altered the baseline by giving this intensification, as was done in Formula 509. So while we may be happy about some of the outcomes and we think quality of life did get back to baseline, was that good enough when the baseline was so poor? So that's a point to be made. And when we talk about our high-risk patients, as in the GU 18, we have to say one high-risk feature, which is what was needed for that study. We know there's a way to parse. We know there's a favorable high-risk group, and so I'll be interested in what the RTOG study, NRG study shows there. We know that there are genomic and other characteristics that we can be looking at to say, this is a patient in whom I don't need to push for 3 years. Maybe 18 years of ADT is enough because I'm able to dose escalate.
18 months,
18 months. Yeah. 18 years would be a whole different story. But yes, this idea that, again, with dose escalation and radiation therapy, we don't need to be bound by the fears of before, as long as we still remain humble that yes, toxicity happens, but we can support patients and we can avoid these toxicities better than we ever have before, including with SBRT and focal boost. So
fantastic. Well, Sophia and Neha, thank you, ladies, for your thoughts and your comments. Really appreciated. So that's day one, radiation oncology off to a very strong start. All right, so here I am out for a morning run, and we're in front of the Palace of Fine Arts. It's gorgeous, and I'm here with my good buddy Tyler Seibert, avid runner, cyclist. I think you dabble in some radiation oncology too, Tyler, don't you?
Every once in a while. On Wednesdays. On Wednesdays, I do radiation oncology.
On the other days of the week, he just has a good time.
That's right.
So Tyler, thanks for coming out on this morning run. It's not too cold.
No, it's really nice, better than last year, and beautiful, and super fun to catch up.
And what have been your highlights from ASCO GU 2024?
Of course, best thing is just meeting up with all the friends and collaborators, and that's always the best. But we had some really good science this year, and the highlight for me has to be the GU 18 trial, where we saw with a dose escalation of radiation a tremendous benefit in a randomized trial for patients, including overall survival. I think we're going to have to look at the details of that to really see what that means. It's different than what we've seen with other trials, but now between that and the FLAME trial, we're seeing a real benefit for patients with high-risk disease of trying to get the radiation dose higher to the tumor. So that's exciting.
Yeah, it is exciting, and first time we've really seen those sorts of results, right?
Yeah, seeing a survival advantage with a change of 10 gray is quite unusual, and like I said, we'll have to take a close look to make sure that we think that was really the driver of that. But consistent with what we've seen in other trials, POP-RT, FLAME, and this one, we are seeing at least better control of the disease and in some cases less metastatic disease. So, and critically with no increase in toxicity. Right?
That's the interesting bit.
Yeah, well, and that's the part that's the most believable, really, because that's now been consistent with FLAME as well. So I'm partial to the idea of focally boosting really high to the tumor, what you can see on MRI. And not trying to push too much to the entire prostate. I don't think that's quite necessary. But now you have 2 trials showing really great benefit, and I'm even more motivated to make sure that we can teach everybody how to do this and get technology into the hands of community physicians and generalists so that they can benefit their prostate cancer patients, beyond just the expert centers.
Fantastic. Well, it's too nice a day to keep talking science, so I think we should continue our run.
Let's go.
All right.
Thanks so much, Renu. It's a total honor to be actually guest hosting GU Cast. So, my first go at this role, it's a real pleasure to introduce Dr. Sam Washington, who is my junior partner at UCSF, former resident, fellow medical student at UCSF on the You Can Stay Forever plan with us, and been making us very proud at UCSF, one of actually many graduates we have around this conference, which is terrific. So, Sam, welcome.
Thanks for having me. Excited to be part of it.
Great. So we are here at ASCO GU, 2,000 people back in full force in person, 300 abstracts. What are your highlights so far from Prostate Day?
I think it's exciting to see in prostate cancer so much work being done on how we can improve care. So that's around ADT, treatment, intensification, de-intensification, changing how we discuss prostate cancer, low risk, how we can improve the management of that. At a systems level, at a population level, and then also from a disparity standpoint, we are diving into data in ways we didn't look at it before, how we can change how we screen men, all exciting things that are being discussed that I didn't really see to the same degree even a few years ago. So very exciting.
You covered the whole spectrum. So let's start at the left. Let's start at the left. What's the best thing going on in screening?
So now there's a lot of interest in how we can do it better. So multiple discussions, risk-based screening, how we can tailor screening for patients, and then how do we tailor it for populations who may be at greater risk. So Prostate Cancer Foundation, screening guidelines for Black men is part of that discussion, which is exciting.
Any tangibles yet? I know you have thoughts on this too, so feel free to. No, in all seriousness, how do you think there are differences, or do we just need to be screening Black men more consistently under current guidelines? What are your thoughts?
I think that even if we were to come out with new guidelines or updates, the question is, how do we make that happen?
Yes.
And that is really outside of our usual clinical bubble. So I think a lot of the screening discussion has to be, how do we optimize screening and the burden for primary care docs who do the screening, and do it in a way that's risk-based and facilitate screening for them without a greater burden to their clinical work. And I think that's the part we have a lot of work to do, but it's exciting.
It is
exciting area.
It is exciting
for us to dive into.
So getting into diagnosis, what about localized? So you talked about both systems level interventions and kind of personalized medicine interventions. What's happening here that gets you excited in that realm?
The debates of how do we manage over-treatment of Gleason 6 disease is an exciting area. Many different informed discussions that are very exciting on both sides. But I think it again drills down to, at a policy level, how do we change practice to improve care, minimize risks for a specific population? And I think that is the question that's most interesting. I think this is one way that we could do that indirectly. And I think with the data that we have coming out from Aqua, other data sources, we have ways to feed that back. So it's more an iterative process than just a paper that's disseminated into the ether.
This is the implementation science challenge, right? So where are the most immediate directions that you've either seen here or think you want to see by the time we reconvene next year?
So I think in that space for a remit. So I think often the discussions that we're having now, roundtables about this, key stakeholders and leaders in the field talking about how do we proceed with this, I think are the most interesting thing. It sounds like there are efforts at each institution to dive into this a little bit more, which is exciting. And we'll have to see how we can scale that beyond the institution, which is interesting as well.
And to get out into the community outside of the institutions in the first place. And then finally, what about advanced disease? So you mentioned ADT and kind of some of the more, as patients progress down the journey, what have you seen here so far today?
I think there is a lot. And as a urologist, I'm like, okay, how much of this will I do? But I need to know what's happening.
Of course.
And our drugs, our diagnostics have improved so much. We have so many tools. But the question of sequence of when to use them, which one first, which one's in combination, no one's ironed that out yet. I don't think there's a perfect answer yet. And I think that's the exciting part. Should we dial things back? Should we do more? When should we do them in sequence? The devil's in the details, but that's where it's exciting.
You alluded to urologists doing this. I mean, as we've already said, it's a big country. And access to care is different in different places, right? I mean, I would assume there are some places where urologists are doing more of this because there's less oncology coverage. I mean, what do you think we need to be doing to get the messages from this meeting out into boots on the ground? Practice, whether it's done by the urologist or the oncologist?
I think so. I always say, no matter what I'm looking at, context matters. So if you're at UCSF, that context is going to be different than if you're practicing in rural Georgia. But I think now we have access to data so we can look at those different areas. And that's where it's the implementation of public health. You're like, okay, now I have a difference in disease patterns, survival patterns, treatment patterns. How do I work with local policy, local stakeholders to affect change in that area? Because that recipe is going to be different depending on where you live.
Very exciting. A lot of work to do.
Yeah, it's exciting. But this is like, we now have the data to inform these things. We just got to move beyond recalculating the same data.
That's step one, maybe even step two. So hopefully by this time next year we'll have yet more to say. So. All right, so shifting gears just a little bit, and on the topic of disparities, you and I have been talking for a while about this question of whether there are disparities in active surveillance, both in uptake and outcomes, by race and by other social demographic factors. I know there's a paper just out recently. What are your thoughts on where we stand in the field?
I think it is a blind spot that we have. We talk about disparities, kind of patient level factors or system, but don't really specify that or acknowledge that we're part of that system. So the question is really, when we see patients who are candidates for active surveillance, how are we managing them? How's that management change based on race? So are we seeing differences based on race in even the discussion or implementation of active surveillance? And it sounds like, based on a recent paper that came out on cancer, that there may be a proportion of practicing urologists in which that's the case. Now, context matters, absolutely, and there's a lot to drill down in that, but I think we still have to talk about, okay, for low-risk disease, irrespective of creed, how are we managing that, and do we need to optimize that to minimize over-treatment, over-risk for everyone that would be eligible?
Do you think this is true? Your paper from SEER Watchful Waiting a couple years ago showed, risk ratio 1.0, right, with adequate adjustment. If I recall right, there was lower use of surveillance for Latino men, for Hispanic men, but like no difference for black versus white.
Right.
The one we had up from Aqua, there was a slightly lower likelihood of surveillance use for black men. If you think about the totality of the evidence, do you think this is true? Is this a disparity problem?
Well, I think it's a disparity, but maybe not in the way that we frame it. Okay. So we're always talking about a kind of a disparity in terms of biology, outcomes, but I really think it may be a disparity in patient-provider interactions, shared decision-making, counseling, and that's where all the context, the qualitative work needs to be done. So we understand, because we know who you see and where you get your care impact the care you're going to get. And I think there's enough papers to show that that's the case. We just need to drill down in that context more. And we can't do that with SEER or NCDB.
Well, and as we were talking about earlier, if we want to make a huge difference in the disparity in our lifetime, even your lifetime, let alone mine, it seems like better screening among younger black men would be a huge step in the right direction. But we can't do that unless we're going to surveil the tiny specks of low grade, maybe not even cancer, if we find it.
Right.
So, but which raises the other question: are outcomes different, grade for grade, stage for stage, in black versus white men? On AS.
I mean, I think we have large studies looking at this. Capture has looked at this, the VA has looked at this, and the disparity is not as large as SEER or other real-world data sets when you start to control for practice patterns. So that tells us that practice is impacting the disparity. We just haven't dived into that delta the same way we have income or insurance or any of the other factors.
Well, and look, serum and NCDB also don't have the same clinical granularity that say capture does, because obviously controlling for low versus intermediate risk is not the same as getting down to the number of cores and all this sort of thing.
I think that brings up an important question when we talk about screening, active surveillance, treatment counseling. What things are we not measuring, modeling for with the data we have? So if we are to go down this route, we need to think about, okay, after the event, what's the follow-through? How are we creating a pathway in which we're not just feeding a leaky pipe, but actually plugging some holes?
So at the end of the day, fundamentally, and this is opinion territory, do you think we should manage black men any differently than white men in terms of active surveillance, or genomics, imaging, different schedules, or grade for grade, stage for stage, we should just think identically once we've got the diagnosis?
I can't say that everything would be gone, but I can say that now we do not do the same thing for everyone. And I think if we eliminate that delta, a lot of this disparity is going to go away, as we've seen in other data sets. I don't think we're there yet with our contemporary practice and what we do to truly see it, but I'm excited to see how it impacts the delta.
Super. Thanks for joining us.
Thank you.
Okay, so I'm here with Dr. Seema Porton. She's an associate professor of urology at UCSF and one of my mentors during fellowship. Seema, it's always wonderful to come back to San Francisco, and one of my highlights is always catching up with you and the kids.
It is always lovely to have you. We're in my home today doing this interview, and it's always lovely to see you.
And how was your ASCO GU 2024?
It was amazing. I think it was really exciting to see all the progress that's been made across GU cancers, and it was always amazing to catch up with old friends.
Fantastic. And one of my highlights on the Bladder Day in particular was the session that you moderated, and that was on the management of node-positive bladder cancer, which is a controversial area.
Yeah, I think in particular with the announcement of EV Pembro's data in first-line setting, it's sort of complicated how we manage patients who are node positive or have a high single retroperitoneal node, so M1A, and should we be managing those patients more like our metastatic patients, and when do we offer local consolidation? And it was really interesting to hear from our panel of speakers their approach to how they would manage my patient's case, which is kind of actually in development.
Yeah, yours was a really interesting case, and we won't go through all of it, but if you could maybe give us the main take-home points for options for treatment of especially younger patients with node-positive disease.
Yeah, so systemic therapy is the backbone for treating this disease, and she was treated with Dose-Densemvac for almost 6 cycles and had a difficult time tolerating it. And I think that no matter what systemic therapy ends up being the clear winner, that is an important component of the management of this patient. Many folks had a lot of interesting insights and ideas on what do you do with the bladder if that is the only site after a complete clinical response. And there were a multitude of recommendations and options presented, and a lot of it is going to get back to discussing with the patient what are their symptoms attributable to local disease, and also in terms of quality of life, what is their preferences, right? Whether you choose radical cystectomy, radiation therapy, or TURBT with intravesical therapy. And there was good data and points made for all of those options for local control. But I think this just highlights the need for further ongoing studies. And there are a few kind of currently underway looking at how should you manage these node-positive patients.
So it was really handy, wasn't it? Because you had an international multidisciplinary discussion for your patient. Did you get some ideas?
Yes, I did. I indeed did. And before this meeting, I asked for permission to present her case and show her imaging. And I said, you're going to get the biggest tumor board that I think is possible. And so have some ideas, yeah.
Fantastic. Seema, thanks for joining us as always.
Thank you.
Okay, so kidney cancer had a big day today. Keynote 564 made the history books by becoming the first trial to show an OS benefit for adjuvant pembrolizumab in the treatment of patients with kidney cancer. And I have the man of the hour here, Dr. Toni Choueiri. Welcome.
Thank you for having me.
You must be exhausted.
I just want to sleep.
So go on. I mean, you presented it this morning. It was fantastic. You know, I think everyone wanted to just stand up and give you an ovation, really. And it looked like it was quite emotional for you.
It was. I mean, it was. 51 years in the making. You dig back and back and back into that literature that was not like you have to go back. There are some studies published in German journals, of immunotherapy, randomized controlled trial. First trial was in 1973. None of us here were born, I believe, when renal cell was called hypernephroma. Imagine, radiation was worse than giving nothing. On and on and on. 12, almost 13,000 patients put on, trusted us, urologists send us patients, and finally we have not a disease-free survival, but an overall survival benefit that I believe, many of us believe, is not just statistically significant, but is clinically relevant. Close to 40% decrease in the risk of death after close to 5 years follow-up.
Yeah, so that's right, 38% reduction in the risk of death, which is huge, really. The question does remain of how do we select patients for treatment?
Currently, I personally follow Keynote 564 eligibility. I follow it, really religiously. I apply it, but there are some, exceptions. If someone comes within a year and a half, what would you think, especially with resected metastatic disease? What about this person that have papillary RC, a tumor that does respond, especially if they have very, very high risk and they're young? What do you do here? This was not included. Of course, the ideal way to see if patient need adjuvant pembro is by having a way that can predict almost 100% micrometastatic disease. Currently, all what we have, TNM staging and great, which is something we knew for the past 20, 30 years plus. So I think the future, I don't know if we're going to perform a new study, but the future is going to be bright with novel blood-based biomarker that may come late. And this is not just NGS or bespoke assay. I think there are methodologies that involve that sequencing, but also involve looking at the epigenome, looking at methylation, looking at the whole genome, not as target panel. All this going to converge together. Maybe we'll, looking at slide and having a very strong baseline prognostic factor, through artificial intelligence can increase, add something substantial in addition to TNM and grade. Today, though, all what we have is the clinical classification.
Well, Keynote 564 deserves its very own podcast episode. So, Toni, we will get you back on GUcast to discuss this in much more detail.
I would love to. Just get me, don't get me Alex Kutikov, just get me Ben Davis. Get me Ben Davis. I can handle Ben, but Alex, impossible.
We just have to figure out the background music for you and Ben Davis then.
Absolutely. And the wine. Ben thinks he's really, great in wine selection, and I think he's average.
We need your expertise. Now, the publication is on the way?
We can say it's on the way. Let's see. Yeah, soon.
Soon. So there you have it, Toni Choueiri. Go and get some rest. You look like you're about to fall asleep.
Actually, maybe under the table here, we can hide it, and just half an hour nap would be great.
We'll feed you some wine under the table. Thanks for joining us.
Thank you.
Okay, so I'm here with the European Urology Oncology Editor-in-Chief, Professor Morgan Roupret. Morgan.
Good afternoon.
Hello, are you enjoying the conference?
Yes, it's fantastic to be here. The big network of GU cancer is there, medical oncologists, of course, radiation oncologists, and of course the urologists.
ASCO GU is a very unique meeting, isn't it? Because it's a very multidisciplinary forum, unlike a urological meeting.
That's true. It's a big event, but there is one room, so everybody is going back from the meeting with the same information, which is an advantage. First day is prostate cancer, 2 days bladder cancer, tomorrow will be kidney cancer, so really exciting with all the big release that we have during the conference, and we are chasing the authors for them to release their data in the journal.
Yeah. And this is very relevant for you because, you know, as the European Urology Oncology Journal, it's a very oncologically based journal. And so, you know, the multidisciplinary representation at this meeting would be particularly relevant for you.
This is true, and your presence here is also extremely important to demonstrate that with the journal we are in a dynamic process to always discuss around the data, which is true in the corridor of the conferences, it's true in the podcast that you coordinate, and it is true within the 6 issues of the journal.
Fantastic. Well, all the best for the year as Editor-in-Chief, and we look forward to seeing you at the next meeting.
Thank you, Renu, to be part of the team.
Well, I hope you all enjoyed that as much as I did. Thank you very much to Renu and to all her guests on this highlights package of ASCO GU. We'll be back very soon again with some cracking episodes lined up this week. Stay tuned for some quite controversial views on some of the papers presented at ASCO GU. Plus, we'll be focusing on the randomized trial of transrectal versus transperineal biopsy with lead author Jim Hu. Stay tuned.